afternoon's meeting of the Health and Wellbeing Board. Apologies for the delay, but had a bit of a technical problem, which we think has now been resolved. But I'd like to thank members of the public who are listening in and people who are here in public. We do have some newcomers, so I'd like to can I welcome back Dr. James Burden, the clinical place lead for Rutland, and Emma Jefferson, from Citizens Advice Rutland. I always want to put CAB in there. And we have Councillor Christine Wise, who's here for Councillor Smith, who is unfortunately not very well. So we have another busy agenda for today's meeting. So the practical matters, we're not expecting a fire alarm. If the fire alarm does sound, can you please leave via the nearest exit? Rallying Park Point is at the rear of the car park. Please raise your hand if you wish to speak. And for the benefit of the webcast and recording, switch on your microphone when addressing an item and switch off when you've finished speaking. I will refer to the scrutiny officer from Democratic Services if I need to record a vote or for any procedural matters. So thank you. So let's move on to, first of all, Jane, have we received any apologies?
Thank you, Chair. Yes, apologies have been received from David Williams, Ian Crowe, Sarah Premer, Councillor Tim Smith, though we have Councillor Wise attending. Apologies have been also received from Simon Barton and Simon Pizzi. We were due to have Ashley Epps here, but it doesn't look like she's here at the moment. And we should have had Joe Grisell as Sarah's representative.
Okay.
The Chair, Jo Grisell should be joining because she's presenting the dental paper, so if we could just keep an eye out as she...
Let's hope she arrives in time. Thank you. So I'll update if we hear anything else, so thank you for that. Record of the meeting. This is to confirm that the minutes of the Rutland Health and Wellbeing Board meeting held on the 23rd of July are an accurate record. Would anyone like to make any amendments? No. So I will propose the minutes. May I have a seconder, please? Thank you, Debs. All those in favour, please raise your hand. Thank you. And anyone wishing to abstain? Councillor Wise, who wasn't here. Yes, because you weren't here either. Thank you. The minutes are now confirmed. Action. Okay. Action arising. There's no action arising, so we'll move on to item number 4. Does anyone have any declarations of interest they wish to declare? Dr.
I have various declarations of interest in terms of I'm the clinical director of the PCN, which is a provider organisation, and in this role I'm the place lead, which is a commissioner. So it's just to make sure you're aware of that, really.
Petitions, deputations and questions. Have we received any?
None received, Chair.
Any questions with notice from members?
None received, Chair.
Any notice of motion? Oh, that was a question. Any notice of motion from members?
None received, Chair.
Thank you. So we now have, this is going to be interesting. Line. Thank you for that. So, dental services in Rutland, report number 1072024 from Deborah Mitchell, Deputy Chief Operating Officer, and Joe Grisell, Senior Planning Manager, LLR ICB. We had been informed that the report would be presented by Lewis Parker, who's there. Oh, good timing, Lewis, thank you. Who is the Commissioning Manager for Pharmacy, Optometry, Dental and GP Services from the East Midlands Primary Care Team. And we have a number of representatives joining us virtually, including Joe, who is now on screen. And do we have anybody else? Jo will tell us who else is going to be attending from her side. Thank you.
Hi, so I'm Jo Griselle. I'm the Senior Planning Manager with the ICB. Accompanying me today, I've got Jenny Oliver, who's from NHS England, who was the author of our Oral Health Needs Assessment, and also Lewis Parker, and of course, Deb Mitchell there as well with you. Hopefully you've had a chance to read the paper, and I'm just going to go through a series of slides with you and give an overview of where we currently are. Jane, are you able to share the slides?
You need to share the slides on your screen, Jo, with the rest of the board.
Okay, I'm going to struggle with that because I've only got my laptop at the moment. Deb, would you be able to?
Hang on, let me have a look.
Jo, I'm not online, so
Hang on. If I share my screen.
Thanks, Jane. Thank you. That's right. Brilliant. Thanks, Jane. So can you just move on to the first slide, please? So I thought it would be helpful to give a bit of background, first of all, before we move on to the overview, just to recap on how we came to have delegated services. So the ICB received the delegation of services from April 2023. As part of that, the NHS England support team were transferred to a host organisation, which is Nottingham and Nottinghamshire ICB. They continued to support the ICB with service commissioning. Lewis is a member of that team, and they're called the East Midlands Primary Care Team. Right, so this slide gives an overview of the current situation in Rutland, which has 7 GDS providers and 1 8-to-8 365 provider. However, we do acknowledge that we have to improve on this. Can I have the next slide, please? This just gives a very high level overview of where we are with dental performance. Unfortunately, performance across Rutland isn't the best. However, with the introduction of the new patient premium, a number of additional UDAs have been delivered, but we do recognise that we've got further to go. Can I have the next slide, please? So a bit of background about the Oral Health Needs Assessment. This has been authored, as I've said, by Jenny Oliver. It's being completed and is currently being taken through the ICB's governance process. This includes the ICB's Strategic Commissioning Group later this month, excuse me, and the Clinical Executive and Health Equity Committee early in November. And after that, it will be published on our website with key messages to stakeholders and the public. This has highlighted, however, that Rutland has lowest levels of dental access and the largest decrease in access since the pandemic. I'm going to hand over to Jenny now, who can give a bit more of an overview of the assessment.
Hello everyone, I'm a consultant in dental public health and I work across 3 ICB areas, including LLR. This needs assessment was written across LLR, which does mean that Rutland tends to come out quite well in terms of oral health. But of course, oral diseases rather occur in a social gradient. So at all levels of affluence and deprivation, there will be people that suffer with oral disease. And I'm sure you're seeing that locally as well. So there are inequalities in oral health and there are inequalities in access to care. And access to care is where Rutland really comes out as disadvantaged when you look across LLR. So we have lower levels of access for children and for adults, and it's lower than the England average. We've also seen the biggest drop in access in Rutland across the whole of LLR since the pandemic. So it's quite clearly a need to be addressed, and that comes through in the recommendations. I'll leave it there, Jo.
Okay, thank you. Can we move on to the next slide, please? Commissioning plans. I'm going to hand over to Lewis, who's going to talk us through this, but just to note that we're currently working with the East Midlands Primary Care Team to develop our 3-year dental plan from 25 to 28, and that will include a number of the initiatives that came out from the National Dental Recovery Plan earlier this year. Lewis, can I hand over to you now, please?
Yeah, no problem. Thanks, Jo.
Thanks.
So, yes, as referenced, work is underway to improve dental access, and some of these have been referenced, some of the work streams have been referenced on the slides previously shown. So as part of the Dental Recovery Plan, which was announced back in February, so this was a nationally mandated series of work, all practices across LLR received an uplift to the minimum UDA value, and that was to bring that value up to £28 per UDA, and that included 2 practices who were under that £28 mark out of the 7 from Rutland, so they're now up to the minimum rate of £28. The new patient premium scheme as part of this dental recovery plan, which all Rutland providers have been opted into, which incentivises providers to see new patients who haven't been seen in 2 years. Additionally, the Golden Hello Incentive Scheme, which is currently out to receive expression of interest from providers across LLR. So this is a scheme looking to attract workforce to areas that need improvements to their access, and that's done by offering bonus financial payments to new dentists, basically. And 4 places have been funded across LLR. Lastly, work around the 110% overperformance scheme. So that, I think that's currently pending approval, but that would allow certain providers selected across LLR to overperform their current dental contracts as well. And additionally, we're currently underway with a procurement to redistribute 10,000 UDAs back into Rutland. So due to procurement timelines, there was changes at the start of this year that came into effect. If all goes to plan, that we'll be able to start actually delivering those UDAs in February next year. But timescales may depend on how many applications we receive. If we only receive 1, that obviously makes things very straightforward, but there'll be more time to moderate and things like that. So, but we are working hard to get that activity delivered as soon as possible. I'll hand it back over to you, Jo.
Thank you. I just wanted to add finally about the actual other initiatives that are ongoing in partnership with Leicestershire Public Health colleagues around oral health awareness campaigns, so the supervised toothbrushing with nursery staff and infants, and other things that are being delivered as well. I'm going to pause there so we can open it for questions, if that helps.
Right, Debs and Daub.
Thank you, and thanks to the presenters, and apologies for anyone listening. We have had a dog barking in the background that's thankfully stopped, so hopefully you've been able to hear. It's not a question, it's just a statement really. We absolutely acknowledge that we haven't got enough dental provision within Rutland for NHS access, both for children and for adults. This is a national problem. It's a particular issue for Rutland, specifically around rurality, rather than underlying health in particular, although there is something in the report which I'm sure somebody will ask about, and that's about the dental admissions and extractions. And I just wanted to know whether that was more 0 to 19-year-olds go to hospital for the extractions, or disease is worse for 0 to 19-year-olds in Rutland, because I wasn't quite clear from the report, and I'm sure somebody's going to ask that question, so I don't know if Jenny's able to come back on that. The national actions that have been put in place, some of them Rutland haven't benefited from. One of them is the Golden Hello. So the Golden Hello tries to attract dentists into NHS dentistry in specific areas, but it takes dentists to actually come and take up that offer. Sadly, nobody in Rutland has taken up that offer. So we need to look at other ways in which we can try and promote provision following these actions. So this isn't we acknowledge there's a problem with NHS dental access in Rutland and we're doing nothing about it. There's a national action plan. We're working through those. We know it's not going to address all of the issues, so there's more for us to do. So this effectively is a position statement as to where we are now. We though, as a health and wellbeing board and alongside all of our providers, and the voluntary sector, we need to do more to encourage some of the wider influences to oral health in Rutland, as well as across LLR, so that we get people brushing their teeth and some of the other healthy eating, etc. So that we need to take the prevention arm as well as the treatment. So I don't know if Jenny can come back on the point in that specific point in the presentation.
Yes, the hospital extraction rates. I deliberately didn't mention it in a way because the data is very unreliable. So it's very tempting to draw conclusions from it, but it's dangerous to do so. And that's just because of the way that the service is delivered. It's delivered by a service that comes into the hospital, uses the theatre and then leaves again. And they don't always submit their data through the hospital data sets. So essentially, we can't draw conclusions from it because we can't rely on it. On the other hand, it is worth bearing in mind that in order to get to the point where you're having an extraction under a general anaesthetic in a hospital, you have to get through the gatekeeper of the general dentist, who then refers you on to that. So it could be that as access is low, there are people that need hospital extractions that aren't able to get it because they need to get through that gatekeeper first. So there is a principle there to bear in mind. I wouldn't focus too much on the data because, as I said, it's not reliable. Does that answer your question?
Yes, but apologies. Yes, it does. And it might be something that we need to pick up offline about what we can do to improve that local data. Thank you.
Yeah, that's a national issue too, by the way.
Thank you very much. I'd like to move on to our second question. Dawn.
Hi, Dawn Godfrey, Director of Children's Services, Rutland. I just want to kind of explore that point a little. I think I might be making a similar point to what Deb was raising, but I just want to push it a little bit more because I'm a little bit confused when something, given the statements that are in the presentation. So it says that Rutland has only 15%, one of the lowest proportions of children with decay experience in the ICB area. It then goes on to say that Rutland has the highest rate of hospital extractions for 0 to 19-year-olds. And so I might be making links here, but I do need to understand, and I think we all should understand what that link is, because is it about purely that actually children in Rutland are cleaning their teeth and they have low decay at that 5-year-old stage, but then something is happening post 5 and their teeth are getting worse, so then it ends up flipping, so that instead of Rutland having the lowest level of decay experience, clearly something's flipping for Rutland children to have the highest rate of hospital extractions. And so is it something about the preventative arm that we need to really concentrate on? Is it about actually access when decay is first seen and it not being that children are not getting the access and therefore their teeth are getting worse and hence the hospital extractions? I do think we need to understand that, because I don't know why because then coming on to the actions from a public health point of view, I'm not sure if those initiatives are going to make a difference for my children in Rutland.
Deb, would you like to?
So I'll come back on that. That was, and Jenny wants to as well, that was the point I was making. I think what Jenny is saying, the data is not reliable enough to be able to determine it, which is why I've said I think we need to do some more work outside on that specific issue, because it is a very good point. The lower rates are for under for 5-year-olds, but we know Rutland has low dental access both for children and adults. So we do need to determine more around that data. It could be that there are, it's not the overall extraction rate, which is one of the things that I would want to see. It could just be the hospital extractions. So I think rather than debating it more here, unless Jenny wants to add anything more, it's a piece of work that we need to take offline and come back and with some further information on, acknowledging that it might be difficult because of the data issues that Jenny has.
Jenny, yeah, do you want to come in?
Sorry.
Just a couple of things there. That I absolutely agree that we can't draw conclusions from the data. As I said before, the fact that the activity looks high is probably just that more data is flowing through the hospital data set here in Rutland than in other parts of LLR. It doesn't reflect the true level of activity. So again, I would caution you against drawing conclusions on the basis of that. In terms of why oral disease is lower, oral disease is very strongly associated with deprivation. So if you have a relatively affluent area, you're much more likely to have lower levels of disease. Oral disease has social determinants like other common chronic diseases. So that will be why you're seeing lower levels. And I wouldn't link that to the activity data, as I've already stated.
Jenny, can I just clarify, do you take into consideration referrals across the border away from Leicester into Peterborough?
Yes, because the access levels we've looked at. Do you mean access to dental care generally?
Access to, no, the extractions in particular I was talking about.
No, the extraction data, I would really urge you to disregard because it's so unreliable.
No, yeah, sorry, I understood that. What I was saying was that our patients or our residents can go in both directions, and information from the Peterborough area doesn't come back to us.
Yeah, look, if you're looking at dental access
Northampton
data,
and anywhere else.
dental access data that we've reported in the needs assessment is by location of residence rather than location of treatment. So you'll be able to see what proportion of your residents are accessing care.
Lovely. That answers the question.
That's general dentistry.
Okay, thank you.
Okay.
Deb's got another one, and then Mike, I haven't forgotten you, Mike.
Okay, so just my final point on that. I think given that we know that over 50% of the population go outside LLR for treatment, it could be that Peterborough are better at recording dental extractions than LLR, but we don't know, which is why I want to do some digging offline, if that's okay, with everyone, and then we can follow that up. Thank you.
Thank you very much. Mike, I'd like to come in now.
Sure. Thanks, Chair. Thanks, Jenny, and thanks, Joe. It's just to ask, was there anything new or different found in this oral health needs assessment since the JSNA chapter on oral health that we did probably about 12 months ago? Has anything changed since then in terms of broad recommendations?
Can I come in, Chair?
Yes, Joe.
We'd need to do a cross-reference to see if there's been any changes, and then we can work together to address those. If that's okay.
So can we agree that we have an action coming out of this that you will offline review and collect the data and then come back and report to us? We need to get a clearer picture of what's happening and where we could, if we need to, put pressure and improvement perhaps.
Yeah, that's
Janet.
absolutely fine.
Yeah, for those that don't know me, I'm Janet Underwood and I'm the Chair of Health Watch Rutland. We've been following this dental issue very closely for 2 or 3 years. And I would just like to make the point absolutely that we were promised this joint oral health needs assessment a year ago. It hasn't been delivered. I went to the joint HOSC in, I can't remember whether it was July or August, and we were promised absolutely that we'd get it in September. We're now just going into October and being told that it will be November. And I think this delay is unforgivable given the amount of suffering that is going on in Rutland at this moment, that things are being delayed because this report has been delayed for so long.
Would anyone like to defend the position? Joe?
Hold my hands up. It was delayed in the first instance because we had major capacity issues within the team to actually develop, which is when Jenny came in and took over the reins and produced it on our behalf. Promises shouldn't have been made that it would be republished. But however, what I would like to say is that it hasn't stopped the work from going on. So the 10,000 UDAs that are being recommissioned in Rutland, that process started a couple of months ago. So we weren't waiting for the outcome of the OHNA to actually go forward with that. This has further obviously identified the need that's within Rutland, and we are working really, really hard to address that with our non-recurrent funding initiatives and also our 3-year plan.
Janet, I'd like to reply to that, please.
Yeah, I would, it's a supplementary question, really. I'm not definite, but I have a feeling that initially we were promised 20,000 UDAs, but I will stand corrected on that. However, given the backlog of care across the county, I question whether 10,000 UDAs are going to be sufficient to be able to provide the care that so many people need in this county, because they will all, if they've not seen a dentist for the last 4, 5, 6 years, they will all have a massive amount of treatment needed.
Joe, like to respond, please?
Yeah, I mean, we're getting there, but it's obviously going to be a very, very slow process. The 3-year dental plan will obviously take further measures forward, and there will be further initiatives. But we do struggle to get dentists to take NHS treatment. That's a fact, and that's a national situation. But rest assured, we are looking at the situation and trying to remedy it as much as we possibly can, and what's within our gift to do so.
Deb's right to.
No point on that then. Janet, you raise a really important issue in terms of the actions, which is why I said at the beginning, there are some national actions. It does relate to the dental needs assessment, but we need to take stock once those have been implemented to see where we are at, because although we're in a commissioning process, for example, for those 10,000 UDAs. I think, Lewis, I don't know if he actually mentioned it, providers can overperform by 10% against contracts, so that would give us some more available. If we've got more than one provider wanting to come through, it just gives us opportunities to look at the different elements. And I suppose just to conclude again on this, we know we haven't got enough in place to be able to meet the needs within Rutland. I think that is similar, and although still not right for other places, but our responsibility, and certainly my responsibility as place lead for Rutland, is to make sure that we are doing everything we can with what's available to meet those needs. So happy to have more conversations offline, Janet, and for you to work with us on assessing the outputs of these actions. But when we come back in, I think January is our next board chair, I think it's right, we will be able to feed back some more on that data, and then we'll have a better idea where we are against those national actions and look where we go from here.
Janet, do you feel any more relieved by that?
To be quite blunt, no, because I've heard this time and time and time again, because we've been raising this problem as some people do know, we've been raising it for a long while, and it's just not happening quick enough for people in Rutland. It's just not good enough for them. And I'm sorry to sort of be so negative, but on the other hand, we hear of how much people are suffering, or how much they're having to choose between paying for dental care or private dental care, or paying for food on the table or shoes on their kids' feet. That sort of thing. It's just heartbreaking.
Thank you, Janet. Member of the audience like to make a comment, please?
Okay, Councillor Ray Payne, Rutland County Council, also Deputy Chair of the Rutland Scrutiny Committee, and I have to say, I agree with Janet, this issue, not just for Rutland, but for Leicestershire, this is coming up increasingly, and it is, I'm sitting over there, and it is a sense of deja vu, because I've been to other meetings and very similar things have been said, and I hear delay, I hear a lot of good intentions, a lot of people obviously working very hard, and a lot of concern, but I think we need to get a grip on this and move it along a bit more quicker than we're doing, because it doesn't feel that there's an urgency, or if there is an urgency, it's not getting through to action.
Would you like to comment? Debs?
Absolutely acknowledge what you say and what Janet says. We know we need to do more. It's not through lack of design. This is a really tricky issue to come to solutions with. The only assurance I can give you is that we will do everything in our power to move on. I mean, Janet will know that I've not been involved in this previously. It wasn't commissioned locally by the ICB. But what I have seen from the information and the handovers that we've had, it's a complicated issue. We do know that we need to do more, and we will come back in January with our progress and on what actions we've been able to take.
Right, I'd like to...
Thank you. I'm going to be fair. There's obviously been a very underestimated impact of COVID, which we're coming to grips with. We cannot make private dentists engage in the National Health Service, and it's very disappointing that no one's picking up the golden hello or showing any interest. I accept there are big difficulties which may be difficult for us as a small county to deal with, but with acknowledging that, you know, we have to nevertheless get this ball moving and get along. And I know everybody's working hard on it, but there's, as Janet says, there's a lot of suffering going on out there, and we need to try and stop it.
Okay, I think anybody else like to make any more comments? So, can we agree that it's a urgent area of increased action? Janet in particular has a very strong interest in this area, that we will take it offline, have meetings and bring it back in January with a very strong detailed action and hopefully some improvements.
Absolutely.
We will do that. Just to make one point, and I think we are not going to solve the problem by January. This is a complicated issue. What we will be able to do is come back with the information and take stock of the actions that have been taken as part of the national plan, and to work out what else we need to do locally. Thanks.
Janet.
It's just a suggestion. I do know that part of the national improvement plan was to have mobile dentist vans going to rural areas and coastal areas. I do know that Rutland so far has not been included in that. Is there any option to do that, to bring the care out to Rutland?
Joe, if you'd like to comment on that, please.
I'd need to pick that up with the East Midlands Primary Care Team, because I'm not 100% certain what the criteria was, but I do know that within the East Midlands we were not one of those identified as an area for mobile dental vans. But let me pick it up with the East Midlands Primary Care Team and see what they say.
Thanks for that, Joe.
Yeah, I was just going to add, in terms of mobile dental vans, I know that wasn't areas that we were in charge of being selected, that was selected for us, but also in terms of some of those dental vans, the actual effectiveness of some of those schemes, you might on paper think they're quite effective, but actually it's the people that you would be surprised at how impactful and how expensive they are compared to normal services. So there's just that to bear in mind as well.
I think we've discussed that fully. Anybody else want to make any other comments? Okay, thank you. So moving on. No, on to question. I'd like to draw this discussion to a close. So we note the content of the report. So what we've agreed is that we will discuss this outside this meeting and bring it back to the next meeting in January. And all of those in favour of that action, please raise your hands. Anyone wish to abstain or disagree? No, thank you. So that's been, we have noted the contents. Moving on to number 9, Children and Young People Strategy 2025-2028. We've now got a short verbal update from Dawn Godfrey, Strategic Director of Children and Families, regarding the Children and Young People Strategy. I'd like to hand over to Dawn, thank you.
Thanks, Chair. So it's just a brief update on the formulation of the new Children and Young People's Partnership Plan 25 to 28. It's in the process of being updated, and we've already had an initial workshop, and we'll have another one by the end of this month. And really, the opportunity we've got is to redesign and really focus on 2 priority themes. One being centred around healthy lifestyle and one around opportunities for all. So they're the 2 kind of priority themes that we will be workshopping with our partners, and against both of those there'll be 2 or 3 kind of core activities that we'll be committed to completing over the course of the 3-year strategy. It's due to be signed off by the Children and Young People's Partnership in December, and we'll come back fully. The strategy and plan will come back fully designed up and completed by January to this next Health and Wellbeing Board. It's very much a co-production strategy, both with our partners. As I said, it is a partnership strategy, but also with our parent carers. And the plan is that we will go into dedicated children and young people's consultation and engagement phase following in the spring, in the new year, so January onwards. So yes, that's all I was going to say today, but you will see something more meaty at the next Health and Wellbeing Board. But equally, it was also just to put, there'll be a number of people both listening in, but also members of the board who will be invited to the workshops to workshop up the detail.
Thank you. I'd like to commend you on the process, particularly the co-production and the involvement of parent carers and I think more importantly the young people. I think that should reflect really well. So good luck with it. Hope it goes well. Mike, if you'd like to comment.
Yeah, thank you. Just a couple of comments. I can never work out if workshopping is a proper word, but we'll leave that one go. At this stage, have you got the input you need from public health colleagues, not just Mitch, Susan, Louise and Adrian, but I'm thinking health visiting, the 0 to 5 service, the other public health services. Have you got what you need from the collective public health family?
Let's see if they turn up to the workshop. But so far, we've had very good public health engagement, is what I would say.
Any other comments, observations, questions? No. So thank you very much for that, Dawn. So we could move on now to the item number 10, Rutland Public Health Strategy, report number 108/2024 from Miles Sands I've got here. But you've got a new way of spelling your name, Mike. Director of Public Health, Adrian Allen, Assistant Director of Public Health, and Mitch Harper, Public Health Strategic Lead. So I'd like to hand over to the triumvirate.
Well, thank you, Chair. I'll add it to the list of names that people, how people spell my name at the best of times. So yeah, public health strategy. As we say in the covering report, we've always kind of flipped and flopped a bit as to whether we need a departmental strategy or not, because a lot of the actions that we do, as the strategy says, is multi-agency, and a lot feeds into things like the Rutland Health and Wellbeing strategy and the 5-year strategy for the ICB. But we think there's something about setting out, if you like, as a department, what we offer in Rutland and for Rutland in terms of our principles and our values, what we see as being a priorities and how we want to work with people. Does give us an opportunity, particularly on the plan on the page appendix that we put in, to also just put forward a little bit of stuff that maybe we forget about, which is the scale of the living well, the healthy challenges. I'm sure Dawn will pick up in the children's piece as well, previously referenced, just to give an idea of the challenge that we face in Rutland. So many thanks from me to Mitch and to Adrian, who is online for the content. You know, to some extent, it's not necessarily a radical strategy, but if it's useful to the board to see where we're at and to have it and have a greater understanding of where we're at as a department and feed into the policy making world, then, you know, that's what it's there for. So, Mitch, Adrian, I don't know if you want to comment on that or the detail in the strategy itself.
Mitch, would you like to come in?
Thanks, Mike. Thanks, Chair. Just to add a little bit around the process of putting the strategy together to reassure of what we've done along the way. So it's been pretty much in development for the last year, largely, as you'd imagine, through the Rutland Public Health team, but we have consulted with partners and been to various departmental management team meetings. Councillor Ellison over there. And we also went to the Experts by Experience participation group to discuss it there as well, which we had some really valuable feedback, and a lot of that has been implemented in terms of the latest version. So yeah, a year in development. As Mike said, there's the plan on the page in Appendix B, but also the more detailed version in Appendix A. We're currently working on an easy read version as well to make sure that's all covered off and accessible to all. And just to note, alongside the strategy development, we also have recently put together a public health directory of services for Rutland. So that covers all the services that we commission, we provide via Leicestershire County Council and in Rutland County Council as well. That is publicly available on the website, and there's a link in the paper. And then in terms of going forward, monitoring progress, we will continue to monitor progress across the public health outcomes framework to see how outcomes that we're all responsible for going alongside what we're doing within the public health strategy, and would also contribute towards wider council reporting mechanisms to showcase what we're doing from an outcome point of view. So yeah, it's a 5-year strategy, and we've got opportunities throughout to review how that's going and any sort of amendments we may want to suggest as we go. That's it.
Thank you. Adrian, do you want to come in and make any comments or add anything to that?
Nothing to add, Chair, thank you. I think Mitch has covered everything, but obviously here for questions if anybody has any.
So if I just open it up to the members, anyone like to make any comments, questions? Deb.
Thanks. So thanks, first of all, for the strategy. I really liked the way it was written. I thought it was, although you talk about it being an easy read, I thought it was a really good easy read strategy. Particularly like the 1/2 two-pager at the back. It's a comment really. This is a real opportunity now for the Health and Wellbeing Board and all partners to be able to use this in an integrated way with the work in which we're doing. It's a good check mechanism for our plans that we've already got in place. It'll allow us to just map across and make sure we are still doing the right things, because we're halfway through our health and wellbeing strategy in total, and we're also a couple of years into our health plan. So yeah, really pleased to see this, and I thought it was a really good document. Thank you.
Thank you very much. Sorry, no, Dr. Burtis, you winked at me.
I'm not an economist, but the bit at the bottom right of the summary around economic growth. So it said in the decade of 2010 to 2019 that the economy grew, UK economy grew 20%, and the Rutland economy contracted by 8%. So there's a 28% difference in Rutland compared to the rest of the UK economy. And if wealth and deprivation is linked to health outcomes, and that was before COVID, I think that to me is the arguably the worst indicator on the page, because that indicates the direction of wealth in the county, and wealth is linked to health outcomes. And solving that is an extremely difficult issue that is multifactorial. I think part of it, I'd just say, there's lots of numbers, but I think if you were to, when I look at the numbers of things like that, 28% difference compared to the rest of the UK in terms of economic performance is a major concern for the county as a whole.
Mike, would you like to respond, please?
Yeah, I think you're right. I think it is the one that, you know, it's the figure that people probably don't recognise. And I suppose there's various bits for me, one of which is actually even nationally, one would say 20% growth in 10 years is not, on an annual basis, not a great growth rate in itself. That Rutland's economy has shrunk. Goes to show, I think you're right, the importance of working around economic development with our colleagues in the council and elsewhere. Comes down to that kind of what else can we do ourselves, and the one for me is then the importance of the health and work agenda. So, you know, the more we can do in terms of kind of trying to do our best around long-term conditions, getting people back into the working environment, then that's at least something which we can have a go at ourselves. But I think on that one again, I suppose, you know, the strength of partnership working and the real importance is to make certain we're around the table with Chambers of Commerce, etc., making certain that we're all aware that that has a really massive impact on the health of the population, probably much more so than any individual service we've got.
So I think if we just make sure the statistics don't make it look better than it is, because if you were to quote 28% reduction in economic performance in the county compared to the rest of the UK, then that is a much more alarming figure than 8%, because especially when you look at the graphs, it's quite difficult. So I'm not suggesting in any way at all that it's put out there as a way to deceive. I think the issue is about, actually, it's about prioritisation and fair and obvious statistics, which is always the difficult bit, because in the end, the reality of getting the economy of Rutland going helps every other part of all of the health elements, because that's not easy, though. It's probably the most complex bit of all of the board.
Janet, I think you put your hand up before.
Yeah, does anybody want to respond to James?
I mean, you know, they are fair comments, so I'm not going to respond. I just wonder, shall we pick up in an agenda planning session? I'm just wondering if it'd be worthwhile us considering some of the broader work going on about economic development, economic regeneration in Rutland, and some kind of a session where we can think about the health implications of that. I'm looking across at Mitch because you probably know more about what's going on than me, but I wonder if stuff that we do know that's going on in terms of development, how we might want to have an input into that as a board.
Janet, if you could just hold a moment. Dawn, I think, wants to respond to this. Is that correct? You want to respond to that comment?
Yeah, it was just picking up on and building on what Mike's just said in relation to I think, James, you're making a really good point, and it's something, if you also map it against social mobility in Rutland, we're classed as a cold spot nationally in terms of social mobility. So the sectors that are growing in Rutland are kind of low value, low paid sectors. And the whole point of the corporate council economic strategy is to arrest that and turn that around. And I think certainly from a communities and prevention service point of view, that's really important, and that's one of the kind of bedrocks of our communities and prevention service, is about arresting that social mobility cold spot and warming it up, so to speak, because actually the kind of the links in terms of that and health needs and healthy lifestyles, if you like, and people living well within their communities, you know, the links are very clear to all of us. So I think there is something, perhaps, as a suggestion, just building on what Mike was saying, it might be something that the Health and Wellbeing Board would like to do a bit of a deeper dive into corporately what our economic development strategy is for Rutland, and linking it in with the concerns that are being raised around health and living well.
Good comment. Thank you very much. Deb, is that in relation to that? Yes, it is. So hang on, Janet. We'll go with Deb if that's all right with you.
Yeah, really important points. Dawn. I think we can't lose the fact, though, that the economic development in Rutland has some relation to the population mix in Rutland, and we've got a growing over 65 population, and obviously that's an element of the population that doesn't bring in economic growth. But what it does do is it has a stronger demand on both health and social care. So I do think that piece of work is really important, and we need to be doing everything we can as organisations to help the local economy. And I know some of the Luff bid, for example, sort of tries to address that. But what it does do is it allows us to focus on the needs of our population, our growing elderly population, both from a health and social care, and for us to be able to pick up on some of those prevention elements to keep people well and healthy for longer.
Thank you, Debs. Right, I think we find that conversation, that debate's over to you now, Janet.
Actually, my comment links in very much to what Deb and Adrian and Mitch have been saying. But I would like to skew it a little bit more to something you flagged up a while ago, Mitch, and you've still not... I know you're watching it carefully, but what I'm concerned about is that our life expectancy is dropping, and I would like to know... I know it's not just Rutland, because I saw some stats, I think it was for the whole of LLR, and it's not just Rutland, but I do think we need to bottom out why this is happening, what this trend is going to look like in a little while, you know, in the future, and just get to the bottom of that. If possible.
And particularly for women of an older age.
Yes. And the years of healthy life expectancy, the diminishing.
Are there any... Microphone. Janet. Any other comments? Oh, yeah.
I mean, again, I'm looking at Mitch because I'm not aware of the figures. I mean, the last time we looked at it was that, is it COVID or isn't it, was a bit of a time lag. Now, I don't know if figures have come out since, which either show that kind of, well, we were late going into COVID, therefore we're late coming out of the impact on life expectancy, whether that's changed, it's starting going back up, or whether we're still plateauing on the rest of it. So, Mitch, Maestro. If only you had a DPH who knew what he was talking about and didn't have to rely on you, you'd be fine, wouldn't it?
Yeah, I mean, I'd love to have the perfect answer for you, which unfortunately I haven't got. But I mean, that was the indicator that got updated probably 5 months ago or so, and it's an annual thing. So I know not to plug it onto the next year's data to see if the trend's consistent, but it is our biggest indicator, arguably, alongside healthy life expectancy in terms of quality of life, as well as how long we're living for. But there's nothing, we've got data on pretty much every category of health possible, including economic factors, social factors, environmental factors that contribute significantly, and nothing really plays out significantly. However, things such as the economy that we've raised, maybe they're the ones that are at play, but it's near on impossible for us to say that's definitely the cause. What I can say is all of those elements that do contribute towards it, we either have work streams in place or could look at work streams for economy or dentistry, whatever it may be. And I think there's something in that in terms of us not just trusting the process, but we can look at where them areas are, and if nothing's flagging out, then we're focusing on those work streams with the joint health and wellbeing strategy and all the other transformative programs going on, and we've kind of got to trust it to some level. I know that's not perfect, but life expectancy is a major thing that covers everything, so it's impossible for us to know exactly why that may be and how valid that may be until we start seeing future data sets, because that's a different trend compared to previous.
Right, I've got Debs and Mike, I think. Debs.
Hopefully I'm not going to contradict what Mike was about to say. Really good points, Mitch. The other bit, though that members and the public need to acknowledge is Rutland's a net importer of people over retirement age. So if people come and retire into Rutland, they bring in their historic health needs and underlying conditions with them. So it makes it more difficult to determine what the causal effects are. If it's only people, if we were only monitoring people who have born and bred and grown up in Rutland, I think it would be easier. That and the fact that the population size is relatively small means a small change can skew the outcome more than a larger population size. So yes, we need to do more work on it, but it's not as binary as perhaps it might be. And the health and care collaboration project that we're working on in Rutland is doing a lot of work on health needs assessments and patient need groups. We've heard about it at a previous board. We'll be having further updates later. So that should help the process, and we should be able to triangulate some of that data to maybe give one, some more answers, but two, to make sure that we're getting the right actions in place to allow people to live well longer. Thank you.
Mike, over to you now, please.
Yeah, I mean, again, it's only a small point of listening to Mitch talking. I mean, we can always come back, I guess, when the next life expectancy figures are out and brief the board on that. In my mind, I think Mitch is right. We've got a variety of work streams. I'd be more worried, I think. I mean, I suppose my one fear is that what we are seeing nationally and maybe locally is the kind of after effects of COVID in terms of mortality from cardiovascular disease. So in the mix of work streams, I guess it probably is coming back with as good an analysis as we can do, just try and unpick whether this was a one-off blip or whether we've got an issue there that we need to take account of.
I think hindsight will be a lovely thing, but it'll be a long time to come.
I'm also wondering whether it's the delays, the long waiting lists to get medical care, etc., that we've been experiencing, so people haven't come forward with their problems because it's quite a lot of hassle to get an appointment, etc.
Right. So can I just focus you back? Oh, Adrian, sorry.
Sorry, I just wanted to jump in. A colleague quite helpfully has just sent me the King's Fund latest report on this. And actually, I think everybody that's spoken is right for different reasons. So the King's Fund are saying nationally, life expectancy still remains lower than the 2009 pre-pandemic levels. and it's partly due to heat waves, which obviously we've not particularly looked at, but also the return of flu and other respiratory infections, and as has already been discussed, the disruption to health systems and the care for those non-COVID conditions that were disruptive during the pandemic. So it's almost a mix of all of those things. So the waiting lists are playing into this, but also as people have started to mix back together over, after COVID, those respiratory infections are coming back into play with life expectancy. So it is a national problem, but we are starting to hopefully understand it a little bit more now, so we can have that local lens, the Rutland lens, on some of this data.
Good point. Thank you, Adrian. Can I just bring you back to actually the topic that we were discussing? Sorry, slightly got off track here. Can we come back to the public health strategy and any other comments on that document? So, we'll bring this discussion to a close. It's been a really good discussion. And I think what we're saying here is that we will rely on Mitch and Adrian to keep us informed of what's happening, and to keep an eye on what's happening. So we've noted the contents of the Rutland Public Health Strategy and the contribution to the aims of the Joint Health and Wellbeing Strategy. And I think we've accepted the content. All of those in favour, please raise your hand. Any abstentions? Thank you. It's passed. So the board has resolved that the board has noted, the contents of the Rutland Public Health Strategy 24-29 and its contribution towards the aims of the Joint Health and Wellbeing Strategy. Moving on to item number 11, Leicester, Leicestershire and Rutland Suicide Prevention Strategy consultation. We now have a verbal update from Susan Louise Hope, Strategic Lead, Rutland Commissioning Public Health. Susan, over to you.
Thank you, Chair. We've had a suicide prevention strategy in place across Leicester, Leicestershire and Rutland since 2020. It expired in 2023, so obviously that's one of the reasons for the need to refresh the strategy. A new national strategy came out last year, which is one of the reasons for holding off, in order to make sure that any strategy that was put in place locally gave due attention to the new national strategy. So there's been a process that's been undertaken of cross-referencing the existing strategy to the new national strategy, and also as well taking stock of what we've achieved with the existing suicide prevention strategy, which actually has been quite a lot. We have real-time surveillance data that we see weekly that comes from the police on suspected suicides, and we also have the ONS data, so we've been analysing both sets of data. Obviously, when you look at data in relation to Rutland, you're talking about very low numbers. They're usually in single figures, and it makes it very difficult to sort of like publish those figures, because obviously it could be quite identifiable. So, you know, the numbers have been very low. But I think since 2016 to 2020, there were 12 suicides in Rutland. So we've been through that process of sort of taking stock. We've also set up a working group that has been developing the strategy refresh, and we've done stakeholder engagement as well, and Rutland had representation of all the stakeholder sessions that were held. The stakeholder sessions were very much targeted on those people that either worked in the field or had an interest in the field, because we're very mindful of the fact that, you know, when you're talking about suicide, you know, that can be a very emotive topic for a lot of people, and you don't know sort of the impact that can have. So so that we've had to sort of be very careful with the sort of the stakeholder engagement phase. We've also been undertaking a health needs assessment and an equality impact assessment to make sure that there is no groups that are going to be disadvantaged, in the strategy refresh. The plan is the document is being finalised at the moment. It's due to go to Leicestershire's Cabinet before we're able to open the consultation, but the plan is to open the consultation on the 28th of October, and it will run until sort of mid-December. But the plan is to actually come back to this board in January with more of the details about what's in the new strategy. When all's said and done, looking at the previous strategy and what's been achieved, I mean, a lot of the principles from the previous strategy are actually still relevant and still, would transfer into the refresh strategy. I think that it's widely acknowledged that in the national strategy, I think the tagline is suicide is everyone's business, and that is true. It is, and that's what we're trying to get over in the refresh, is that it is everybody's business. That was in the old strategy, and that will be in the refresh strategy. To sort of come back in January. But obviously when it opens on the 28th, there will be a link that will be sent out that people can go. It will be on the single site so that everybody can go to the same place. If anybody needs paper copies, they can just ask for it and paper copies can be sent out.
Right, Susan Louise, I have the first question, and you're probably going to guess what it is. I don't understand why it's going to, let me get this right, the Leicestershire Board, and then goes for consultation, and then comes here in January.
Leicestershire is only one of the 3 local authorities that actually has to get permission to go out to consult, because Rutland doesn't have to do that anymore, and Leicester City doesn't have to do it. But for Leicestershire, it was a requirement that they couldn't open the consultation without permission from the Cabinet to do so. So that's why it has to go to Leicestershire's Cabinet first. And then and City are waiting on the same thing as Rutland is. I mean, that unfortunately, I mean, this is the thing, is obviously you've got a strategy that goes across Leicestershire and Rutland, so you've got 3 local authority areas whose political processes it has to adhere to, and that's the reason why it's going to Leicestershire's Cabinet and why it's not come here in a fuller form until it will come back in January. But there still will be the opportunity to feed into the consultation.
Kim, would you like to comment, please?
Susan Louise is absolutely right. So we took this decision, the question through our democratic services in the council in Rutland, and their advice was exactly that, same as Cities, that we could go through our health and wellbeing route for approval of the suicide prevention, and we would have to go through JLT and Cabinet for this. I think what's important is about notifying people of that consultation, isn't it? Making sure that people are aware in Rutland when that we've given them the comms. I suppose if you can just kind of put a bit of reassurance about then that for people about how they would access that consultation and the dates. That's really important as well, isn't it, for people in Rutland to respond to.
Yeah, I mean the three com teams have been in consultation with each other throughout this entire process. So I think it was a decision between them to sort of like have a single point of access for the actual consultation itself. But the link will go out so that everybody will be able to have access to that link and be able to go to that link to actually access it online. But like I said, if people sort of can't access online, there will be the facility to ask for paper copies.
Thank you, Kim. I know it's going to be a question that I have to answer, so thank you. I will remind them.
Thanks for the update. I just wanted to check whether the data of the number of suicides that we've had, and indeed the strategy and hence the consultation that goes in place includes the armed forces. or not, because obviously we've got up to 20% of our population armed forces or armed forces family, broad families, and there's a specific issue nationally we know with suicide rates with the armed forces. Thanks.
Yes, it does include armed forces information in the data that we get as well. We have links into the operational group and links into the sort of strategy refresh group of organisations that work specifically with the armed forces and veterans, including the welfare people on Kendrew Barracks. So it does include that data as well. Obviously, it may be different what happens because the military has its own way of handling things. But the police, we have a system whereby when the police, attend a suspected suicide, that they will, involve a service that we have that commission that sort of supports people that have been bereaved by suicide and offer that support to them. So that happens, when at every sort of suspected suicide. Obviously, sometimes people are not ready to accept that help, but the offer is always there, and it will be revisited with those people. And that's proved to be quite a successful service, and that's one of the things that's been achieved by the previous strategy, is the need to support those people that have been bereaved by suicide, and certainly it will carry over into the new one.
Thank you very much. That's very reassuring. Oh, sorry, Mike.
Yeah, there's a couple of bits. I mean, yes, I totally get that different organisations have got different authorisation processes. But if the Rutland one is, it's down to the board today. Yes. I suppose I'm slightly uncomfortable that the board's been asked to approve a consultation on a verbal basis. And in the same way, say it had gone to Rutland Cabinet, there would have been a paper setting out what would have been, this is what we've done, this is the main thrust of where we're going, are you okay if we consult? So I wonder if board are minded to kind of go, yeah, it's good to go to consultation, we could just do some sort of written briefing, because certainly I've seen one with a Leicestershire hat on, and as Susan Louisa said, there is a good news story to tell about the services that have been put in place across LLR, particularly around support for those who have suffered a bereavement as a result of suicide, surviving relatives and families. The developments in real-time surveillance working through Leicestershire Police, I think, are all noteworthy of kind of be good to have a read of that so people know where we're at. And then a broad brush about where we're going in terms of what the consultation will look like. So that's one point. And then the other one for me is, again, a question for Susan Louise again. After the event on consultation, it's a very good reason it's LLR-wide because of the number of pan-LLR organisations involved in it, notably the police. But I'm thinking, I think there was a recent suicide on the A1, so I'm kind of looking for a bit of reassurance once the consultation comes back and we have an LLR strategy, that we've got the joint working with, say, Lincolnshire colleagues, particularly around target hardening on the A1, so to speak. So I don't know if you want to pick up on the partnership working bit and the rest of it.
My font of all knowledge has just informed me that, just to clarify, so Susan Louise, you're going to bring that paper to us in, you're going to bring the consultation paper in January, yeah. And then the results of that paper would come to the Health and Wellbeing Board in April. Yes. So would that make you feel more comfortable, Mike?
I think so. It's whether the routine we're being asked is over the course of the next 3 meetings. You okay if we go out to consultation? Can we now consult you? And now we're going to tell you about the results of the consultation. So I don't know if the next time round is it okay to go out to consultation, or are we expected to comment on the consultation? Not that it, maybe I'll look at Jane anyway, but I mean, not that it makes much difference, but if we're being asked to approve something to go to consultation, kind of feel there should be a bit of information written down about that.
Adrian's got his hand up. Has he got a comment?
Yeah, just to say that this isn't a request for approval to go out to consultation, because we don't need that in Rutland in the same ways we do with Leicestershire. So we've been advised to bring it to the Health and Wellbeing Board to inform the Health and Wellbeing Board of what the process is. So there isn't a request of any kind of the board at this stage.
Mike, are you happy now?
Yep.
We have clarity, so we're going to get the consultation paper. We'll then consult and discuss, and then that'll come back in April with the outcome. So is everybody, so can we as a board, can we note what we've just discussed and bring that discussion to a close? Right, lovely. I've just been informed that unfortunately Alexandra Chamberlain is not available at the moment from the RISE team, so we are going to put that onto a future meeting of the Health and Wellbeing Board. And number 13, which was going to be David Williams, he's been called to away to an emergency meeting, so he won't be able to join us. So moving extremely swiftly on to item number 14, the Pharmaceutical Needs Assessment 2025 Process and Governance. We have received report number 109/2024 from Mike Sands, the Director of Public Health, and Victoria Rice, Business Partner Public Health. So Mike, it's over to you.
Just checking, is Victoria on? Ah, yes, she is. There we go. So just sort of introduction from me. So to remind the board that the pharmaceutical needs assessment is one of the 3 things the board needs to reduce: an assessment of pharmaceutical provision, gaps in service provision, which is the P&A, the Joint Strategic Needs Assessment, and our health and wellbeing strategy. P&A runs on a 3-year, is it, Victoria, cycle, so it is time to go and refresh it. As I say, it looks at the provision of pharmaceutical services within Rutland, maps them out, looks at things about how far we need to travel to a pharmacy, etc., and recommends its gaps in service provision. It's to be used by the Commissioners of Pharmaceutical Services, so it used to be NHSE, now transferred over to the ICB. So that's the kind of bare bones of why we need to do it and what it's about. But Victoria, in terms of a governance process, do you want to pick it up from there?
So with Mike handing over to me, I'm going to hand over to Amy, my colleague, who is going to lead on the Rutland side of the P&A. So I'll just hand over to Amy.
And then Amy's going to hand over to me. We're going to keep it going for another 40 minutes. And then quit.
Thanks, Mike. So yeah, we're essentially just bringing the P&A highlight just to remind you that we are due to publish the P&A for Rutland by October 2025. And just kind of give you a quick run through of the proposed timescales and governance arrangements for the production of this report. I think Mike's already kind of covered, but the responsibility for producing the P&A rests with the Health and Wellbeing Board as outlined in the Health and Social Care Act 2012. As Mike again has said, the P&A has a 3-year lifespan. The previous one was published in 2022 and is available on the website, with the next P&A due to be published by the 1st of October 2025. I won't go through the purpose because I think you've covered that, Mike. We did note in the report submitted to this meeting that there would be new national guidance to follow in developing the P&A this year. However, since writing this report, we've learned that there will be no new guidance, and instead we will be following the national guidance published in October 2021 for the previous round of the P&A. So we have that guidance available now. As part of the process, we're proposing that an LLR P&A reference group should be established to oversee the production of the separate P&A documents for Leicester, Leicestershire and Rutland. This is to ensure a consistent local approach across the areas. The principal resourcing for the development of the Rutland P&A, though, will still be provided by Leicestershire County Council's Business Intelligence Service and Public Health Department. So it will just be kind of information and advice provided through the P&A reference group. The P&A reference group will also be able to provide assurance to the Rutland Health and Wellbeing Board that the final P&A is an accurate reflection of the pharmaceutical needs of the population, and also that the P&A has been developed using robust processes and in line with the national guidance. Appendix 1 of this report does outline the proposed draft terms of reference for the membership of this LLR P&A reference group. These were produced based on the previous version of the terms of reference for the 2022 P&A reference group. We've just updated these for organisational and personal changes, which we think have occurred since then. They're currently draft details, so if there are any suggestions for amendments to these, we're happy to amend these where it's felt that this is necessary. In terms of the work plan and timescales, there are some fixed dates to be observed, which obviously include the final publication deadline of the 1st of October 2025. The proposed timescales are included as Appendix 2 to this report, and the proposal just includes that the first meeting of the reference group and data collection and analysis is to begin later this year in November and December, with the service user and professional surveys, which are conducted as part of the P&A process, due to take place through early spring in 2025. We then aim to have a pre-consultation draft, which should include all of the data and analysis and the results of both the surveys to present to the board for approval to consult on the draft. And then we will have the statutory consultation throughout June and July 2025, after which we'll then work on any amendments and aim to have a final draft towards the end of the summer, which we will then submit the final draft to the Health and Wellbeing Board for approval, which will allow us to publish by the 1st of October 2025. So that's kind of the brief outline of the proposed timescales and governance arrangements. Essentially, it's just for information at this stage, whilst asking for approval from the Rutland perspective to form that interagency LLR-wide P&A reference group.
Thank you. Can I ask a really obvious question here? Do you think an LLR group can actually resolve something like this? Because we're quite different. So the three elements of LLR, are you going to get a fair assessment of availability of pharmaceuticals across the whole place?
So we'll still have 3 separate P&A documents and processes. The group's just there to kind of provide support and governance, and kind of work together to provide information and advice on the process, but there will still be 3 separate documents, so Rutland will have its own P&A.
Right, thank you. And the other one, the other elephant in the room, does this take into consideration the national shortages in certain pharmaceuticals that we've been hearing about and reading about?
So it will cover, Victoria, do you want to cover that one?
Yeah, no problem. So that's one of the things that we were likely to look into. One of the things we tend to look at is what has been prescribed, and then based on what we're told by the pharmaceutical committee for the area. So I'm sure that will come into it. Previously, I remember that work force was quite a big issue. So those are both 2 things that the local pharmaceutical committee will bring up, and obviously that being pharmacists themselves, there are the experts, so I'm sure that will be one of the things that gets included. I can't off the top of my head remember if that's within national guidance, but it probably is.
Right, thank you. Mike, would like to comment?
Yeah, it's an interesting one. It'd be interesting to see with this one, because it felt like when we were first asked to do a P&A and the national guidance, it was a time when supermarkets were expanding into pharmacies and there was more coming in. So the P&A was kind of useful to commissioners to work out where you weren't overloading local pharmacies, and there was a growth in prescribing, as there still is, which was kind of telling us about it. This time around, I suspect it might be sort of looking at the tide going out rather than the tide coming in. So, I mean, it's a useful document, but might be used more to work out where things aren't happening right, as opposed to where the pressure is in the system. And shortages of individual medicines, I suspect that's part of the tide going out.
Hence my questions. Anybody else got a comment?
Yeah, thank you. We're just doing a piece of work. I'm actually just started doing the analysis of NHS communications. And one of the big problems that seems to be coming up time and time again is the fact that when patients go to a hospital outpatient department or they're discharged from hospital and their medications have been changed, there's a delay in the GP getting the details of those changes, and patients are sent on a merry-go-round of trying to get back to the hospital, who say it's not their problem, it's the pharmacy. So they go to the pharmacy and they say, no, it's not their problem, it's the GP. And they go back to the GP, who says it's not their problem, it's the consultant's problem. And people are going round and round on this cycle. I'm just wondering if that can be also included in this P&A.
I'm sure we can look into that. I'm not entirely sure how we will evidence it, but I will make sure we've made note of that and bring it up with the local pharmaceutical committee. I do note that this will not cover hospital pharmacies, which I understand you're talking about discharges, but just make that clear.
Yeah, sorry, can I?
Certainly.
Yeah. I've only got, it's qualitative research we've got mostly. I think I haven't seen the quantitative, the survey results yet, but they won't be statistically significant because there's a low response rate. But I do have the sort of anecdotal evidence which will go into our report. Happy for you to, if somebody gives me contact details, I can.
That'd be fantastic. And if we can have eyes on that report as well, we can include that. Yeah.
Okay. I have Mike's detail.
James, on behalf of all GPs, would you like to comment?
Yeah, I'm not grammatical king at all. It's slightly difficult when you. I always see this as pharmacy needs assessment, not pharmaceutical, because I think it's probably more to do with that. Which, as soon as you appreciate this pharmacy needs assessment, then it takes you away from whether HRT is available, etc. It's been a huge challenge for GP practices for individual drugs availability and effectively a patient, how you're trying to continue a supply of a medication that's in short supply is incredibly difficult. In terms of Janet's point, there is two different elements to medication when you're discharged from the hospital, and actually medication from the hospital. If you have a need for a medication suggested by the consultant in an outpatient appointment, then you should stay in the hospital to get your prescription from the hospital and should not expect to leave the hospital and get that from the GP practice. So the prescription that is generated by the hospital doctor is for the hospital pharmacy only and cannot be used at the local chemist, at which point, if they try and use that as a local chemist, the chemist will say, I cannot use this, this is not an FP10 green prescription, and then the patient will then be directed to the GP practice. The GP practice says, under the contract, we've got 7 days to create this, and often it's antibiotics, and the patient says, but I need this straight away. So realistically, it's for the hospital to be absolutely clear that you cannot get this medication and you have to wait for the hospital issues. In terms of the discharge of medication and the correcting of people's long-term medication prescriptions that are on effectively into the repeat prescription of the patient, and when that is finally correlated, so for example, the patient is discharged and a blood pressure tablet is increased or decreased, and when does their repeat prescription get changed? That's incredibly difficult for you to then do an audit on, because you would need to have patient-specific data as to when their discharge letter was processed and changed appropriately from that point of view. It's not impossible, and it would be down to the providers to choose to give that information. But to do that as a commissioner, effectively, you haven't got rights to that patient level of data. You can ask the providers for that as a marker of quality from that point of view. And that would then need to go, is that from the date that the patient was discharged or the date that the GP practice received the discharge letter to when it was changed, which is, of course, a different issue that's assuming that the discharge letter is written on the day that the GP, that the patient leaves the hospital. So I think I've answered lots of things and solved nothing with that comment.
And I think, sorry, that James is absolutely, and I think, Janet, that actually is going to make your whole research quite difficult because of that time lag, etc., between, and also monitoring, as James says, when it's received. And it's really quite, and personal recollection of the last 9 weeks, trust me, it's impossible.
Say now. No, I'm talking very much, I mean, James is talking from the GP point of view. I'm talking very much from what the patients say and what the patients have told us about their medication and they're getting their prescriptions, etc. So there's a slight difference in perspective of whose perspective we're
I mean, I would say that thankfully many people don't have an awful lot of experience around the process of what it's like to be discharged and how and quickly can I get the medication. And so the difficult bit when you actually truly look at this is where is the education given to the patient and are there any key performance indicators in this for the providers? And so the issue of this, it causes great stress because fundamentally I think patients don't have a very clear educational program and they're generally discharged very quickly, and you know, does the hospital give them a leaflet or how does it get explained, and or how does GP practices catch them and sends them a text message and say, don't worry, this will be changed, we'll let you know. And I'm happy to work with Healthwatch Rutland to try and optimise that.
I just want to flag it because I think possibly it's something that the PNA might want to consider improving from the GP point of view and the patient point of view.
And the hospital.
And the hospital. Well, I don't know that the hospital really care, do they?
Anybody else got any comments they'd like to make? Yes, Debs.
Just a quick one. I know you've used the terms of reference from a previous one. Some of the names have changed and responsibilities have changed. So Claire Elwood doesn't work for UHL anymore. She works purely for the ICB, and we've still got the Commissioner as NHS England. So just need to update a couple of those. Thanks.
Right. Anything else we'd like to? Anybody else? Any other comments? Right. So I'd like to draw this discussion to a close. The motion is noted that the likely timescales associated with the development and publication of the Rutland Pharmaceutical Needs Assessment P&A 2025, subject to any final national guidance. Number 2, to approve from a Rutland perspective the proposal to form an interagency LLR-wide P&A reference group to oversee development of the separate P&As for Leicester, Leicestershire and Rutland. And number 3, that it notes that a draft P&A will be presented to the Health and Wellbeing Board in spring 2025 for approval to consult on the draft. All those in favour, please raise your hand. Anyone against? Any abstentions? Thank you very much. So it's been resolved that the board has noted the likely timescales associated with the development and publication of the Rutland Pharmaceutical Needs Assessment P&A 2025, subject to any final national guidance. Approved from a Rutland perspective the proposal to form an interagency LLR-wide reference group to oversee development of the separate P&As for Leicester, Leicestershire and Rutland. Noted that a draft P&A will be presented to the Health and Wellbeing Board in spring 2025 for approval to consult on the draft. Thank you. Right, moving on to item number 15. Rutland Health and Wellbeing Board Annual Report 2023-24 and Delivery Plan. We now have a verbal update from Fran Hinton, Health and Integration Lead at Rutland County Council, on the board's annual report. Over to you, Fran.
So the annual report, so this is really just to kind of bring to the board a bit of an update around the content of our annual report, and just to have any feedback that you may have if anything has been missed or if there's anything additional you think should be added. So the plan currently is that the 23-24 report, so annual report on the health and wellbeing strategy, will be brought to the board on the 14th of January. So that will be ahead of its publication, obviously into the public domain. So the report at the moment will contain a halfway progress update on the joint health and wellbeing strategy, with a "you said, we did" for the 7 priority areas approach, a forecast for the next half, so what our plans are, what we're hoping to achieve and what that may look like, what has changed, so examples of actual impact that we've had across the county since the strategy has been in place and over particularly the last year, and a timeline effectively of our journey so far. So I've done a bit of research around annual reports and making sure that they are less texty and more interactive, so they're more appealing on the eye. So having a short but interactive timeline of key areas of success over the course so far, so from 2022. There'll be a dedicated section as per on the Better Care Fund. So again, what we've achieved with the Better Care Fund over the last year, what have been challenges and how we have overcome them. And then there'll also, and this is a possible, and some feedback on this would be welcome. There is a possible section on our joint health and wellbeing strategy delivery plan, which I am going to come on to after talking to you about the annual report. So how the delivery plan works, can be accessed, and what to expect from the updates, so from the working documents that I'm going to propose. So I'll also be working with the Learning Disability Partnership Board to ensure that we have an easy read, accessible version of the report also, and it will be requestable in Braille and large print as per standard. Should I go on to the delivery plan or maybe take feedback on the annual report?
I think we'll go with any comments and questions on that one to start with. I look like I've got Mike and Janet. Was that no, just Mike.
Yeah, thanks, Fran. I think it'd be really useful. I guess for me, it's the nature of the Health and Wellbeing Board, isn't it? There is an awful lot we could say about the work we've done if you just put your arms around all the partners in a Health and Wellbeing Board and say, tell me what you've done, tell me what you've done, tell me what you've done. And we need to capture some of that, but really it comes down to kind of identifying what has the board and its subgroups done kind of above and beyond business as usual and the day job. So I'm assuming, looking at your nods, that we're going to have a balance, because if you make it just about that, people go, yeah, but you've left that out. So you can never get it right, but there's a balance for me in terms of trying to stress what have we done collectively, not just as individual kind of silo partners. I'm assuming that's a yes.
Yeah, no, absolutely, and hence the research around how other local authorities and other businesses approach their annual reports as well, because I think that's, for me, certainly always good to get an idea of what's out there. And yeah, absolutely, I could write pages and pages and pages of the successes that partners have achieved. So that hence the idea of the timeline, that we're capturing key impacts. I want to really highlight the impact for the people of Rutland, less about kind of maybe the projects that have been running in the background that absolutely have impact, but I want to highlight what people have seen and felt in the community. So it will be a mix of both. As I say, I'd love to write everything, but yeah, it would take me a year to do so.
Sorry, Fran, would you consider co-production to an extent? Would you involve it? Thank you.
Absolutely. Yeah, this will be co-produced, across the board. So I apologise now if I'm bothering people, but it's absolutely necessary, and it's already started. So yeah.
Yeah. No, I really like the fact that you're going to concentrate more on what people have felt is happening for them in the county. So I think that's really important. So thank you.
And Tracy is going to be integral to that. We've already met about it, which is so important. I want to make sure that what we are putting out there to the public, they can see and relate to. It's important. So.
And I think, having gone round, we should be very proud of what we've done. I think it stands out, and we should be making the most of that. Yes, we'd like to continue to the next part, please, Fran.
Absolutely, thank you, Chair. Okay, so on to the delivery plan. So this is really a proposal to you as the Health and Wellbeing Board. Whether you think that I'm raving mad and I've come up with this, we'll see. So again, I've done a lot of research about what delivery plans look like, and they vary hugely. I've looked at other local authorities, and I've looked at, again, kind of larger, smaller businesses to get an idea of what's out there. So our current delivery plan, so at the moment we don't have what I would maybe like to see kind of in the public domain. So we have our delivery plan, but a lot of things that we're achieving goes to business as usual and goes into the ether. So it kind of gets forgotten about. And actually a lot of the things that we're achieving should be celebrated and put out there for people to see. So the research that I've done, and again, it's into effective and interactive delivery plans that people can read and understand and relate to, has led me to the following. So I propose that we have a new dedicated page on the Rutland County Council website. So this will be linked under health and wellbeing, under the health plans, policies and reports, and it will sit alongside the health and wellbeing strategy and our joint needs assessment as well. So it will be a dedicated page. And my proposal is that we have, and this will be backdated given that the strategy is 22 to 27, that we have an annual refresh document which captures the achievements under the 7 priorities that we have within the strategy. So I tried to visualise this for you, but that's slightly difficult because I also obviously need to keep it in keeping with the Rutland County Council website as well. So this is hence it being a proposal to you guys. So we would have within that document, so it would be an annual document that we would have, and there would be your standard introduction to the Health and Wellbeing Board. There would be a section on our commitments to health and care integration, our joint health and wellbeing strategy, and the 7 priorities. Then it would follow with a section on resourcing the delivery plan. So how are we doing what we're saying we're doing? So the Better Care Fund will come into that, and again, an explanation as to how we're doing things. Then we will go into our priorities. So the best start for life, and it goes down through obviously the 7. So the document will be, I'm aware, quite extensive, but I hope it will make it clear on an annual basis what work we are doing for each priority. So it seems to be the best way that we can break it down into in a manageable way for the public to access. And again, being in a document, you're able to keep it relatively interactive. People that are going onto the website to look at it can choose whether they're looking at archived documents or the current, so for now, for example, the current 2024 document. And again, it would be easy read. We would have braille options, we would have large print options, everything like that would be covered. And then there would also be a section on how we measure our impact. So what we look at and what we do to ensure that what we're doing is impactful. So that would incorporate an impact framework, which again I would design and bring hopefully to the table. And then delivering change through our delivery plan. So just a bit of a summary as to why really we have this document and what the point of it is, and everything like that. So I appreciate a bit of a kind of, I'm sure you're all there trying to kind of visualise it at the moment. But as I say, the current delivery plan is on a spreadsheet. It's not accessible. I want to move away from that. I want to try and capture, and it will support the annual reviews that we're doing, like the annual reports that we're doing as well. So you'd have the delivery plan running annually alongside those. And yeah, that's it.
I'll start first by commenting. I think there are a lot of people out there that will be very grateful for this. And I've been asked frequently where they can find out this information. Yes, the spreadsheet does say it, but it's a very large, quite cumbersome piece of information. And if this works out as you've explained, I think it sounds wonderful. Anybody else like to make a comment?
Thanks, Fran. So I absolutely agree we need to have something different than we've got before. And it does sound really good. I suppose I just want to have a bit more of an idea, because I don't want it to be an industry. We've got a resource that deals with delivery on health and wellbeing items. I don't want to take report writing to take over the delivery actions. So sounds wonderful, as long as you're not taking on too much in too complicated a process away from delivery, if that makes sense. But happy to chat offline.
Yes, just a comment, well, a suggestion really. As you're going through on your website, I'm just wondering whether it would be useful for the public to put a link in to the more complex information that can sit behind if they wanted.
Yeah, absolutely. We can. That's the wonderful thing about it being online. We can make it as interactive as is needed. And I have already kind of started a conversation with comms about the process for having a new web page. So yeah, it will be an ongoing thing. But I'm quite excited about it.
It sounds like it's going to take a lot of time.
Emma, did you want to make? Oh. Okay, so any other questions? So we'll bring this discussion to a close, but we'll move on again into number 16, which is the Better Care Fund report number 113/2024 from Fran, updates the board on the Rutland 2024-25 Better Care Fund Q1 report. Anything you'd like to add, Fran?
No. Nothing else to add. It's quite a straightforward one. No, it is this report, the Q1 report for the BCF team, focused solely on the discharge fund. So you can look forward to a much meatier BCF report come January, when there's a lot more information to read. So enjoy this one.
So I think we'll take that as a no, there's nothing else to read, thank you. So can we draw this section to a close, please? And the motion is that the board notes the Rutland 2024 Better Care Fund Q1 report submitted to the BCF national team on the 29th of August 2024, signed off on behalf of the Chair of the Health and Wellbeing Board and the Director of Adult Services and Health. Notes that the Q1 report solely focuses on the discharge fund as instructed by the BCF national team. And all those in favour, please raise your hand. Thank you. Any abstain? No. Anyone against? Any abstentions? No. Thank you. So, resolved. It's noted that the Rutland 2024-25 Better Care Fund Q1 report submitted to the BCF national team on the 29th of August 2024, signed off on behalf of the Chair of the Health and Wellbeing Board and by the Director of Adult Services and Health, and noted that the Q1 report solely focuses on the discharge fund as instructed by the BCF national team. Okay, moving on to Oh no, point number 19, I'm guessing that because David's not here, we will go straight on to any other urgent business. Have you been made aware of any other urgent business, Jane? No. Oh, sorry. No, that's no. Okay. Number 17, recap. Review of the forward plan and annual work plan. A copy of the work plan is included in the agenda pack, but as stated earlier, the item from David Williams has now been deferred to the next meeting. January's meeting will be very busy, but does anyone have any amendments or items they would like to propose for inclusion on the board's work plan?
I've actually updated the work plan as we've gone on in this meeting. So if I want to, I will share my screen with an updated version. There are currently 11 items for the next health and wellbeing board.
Just to say, we're not going to be able to give due care and attention to 11 items in the meeting. So I do think we need to prioritise what we come back with. We can do that now or do it offline.
Thanks for that, Debs. Yeah, I think it's a fair point. My instinct is to do it in agenda setting, but what I would suggest we do, I'm going to write to everybody and ask them what they think would be the important items to cover at the next meeting, and we will take a poll on what we should include. Would that be acceptable? So we'll do a general consensus, and we may miss some.
Is there anything that's due to be listed that needs to be listed for progression? So there's the view of these are the things that I think be interesting, but if some of them are essential to then go on commission stuff, then that I think needs to be either prioritised and brought about in the poll. Effectively, these are the core things, and then it's all the.
That's just we do a prioritisation grid and put some how important they are, the level of importance. Mike, do we need to put? I can't remember fluoridation in.
That's what I was just thinking, that and the previous item around economic development, but shall we just kind of park them as TBC, because they don't necessarily have to go to this one, and it could be for approval, it could be support, could be for info. So rather than try and sort of work out the detail of exactly what we need for what.
I have a feeling fluoridation has to come to the Health and Wellbeing Board. It's going to Cabinet. No, it's going to Council. Sorry, I knew I was getting it's going to Council, and then I think it has to be rubber stamped by Health and Wellbeing, if I remember that process. So it may well just have to come for a point to be noted. Exactly. I'm sorry, I made an assumption then, didn't I? Yeah, sorry. I apologise for that. Assuming it gets through Council, it would then come to Health and Wellbeing and then go out for Secretary of State somewhere. So there's that process we have to go through. So we've agreed that we will review that list, send out the list to all members of this group. You will comment on being given guidance as to which ones are important in time-wise, and then we will make a vote as to what can and can't be excluded. Debs.
It might be helpful if you're writing out to people to ask them how long they would need and whether the report is for approval, discussion, or what the specific outcome is, and that will allow us to order the agenda. Thanks.
Do that, Jane?
Yeah, because what we can do if a document or any data is just purely for information, I can distribute it to members of the Health and Wellbeing Board without it actually being discussed at a meeting, which it is time consuming, and the board has enough items that it needs to discuss and approve as it is.
Mike?
To chip in on that one, I was just looking at that list thinking the same. There's not much for approval, but looking at the info ones, some feel to me like they are just to receive information. Some feel like we've been asked to provide input. I'm looking at David Williams and the technology one. So some of the other debate is like literally, could you just circulate these? Or although we're not making an approval, you do want our input to help you take your plans forward. So that's the sort of nuance around that bit.
Thank you. Any other comments on that next meeting? No? Okay, so item number 18, any urgent business. Have we been notified of any urgent business?
No urgent business has been received, Chair.
Okay, thank you. So I'd like to highlight to members that the Admiral Nurse Annual Report for 23-24, which was included in the agenda pack for your attention. So if you could just be directed towards that for information. And the last thing on our agenda is the date of the next meeting, 14th of, I'm sorry, Jane.
It's always nice to have reports. The Admiral Nurse Service, just to be absolutely clear, diagnosis rates increased by 50%, relocation of services to Rutland, reducing travel onwards, locally employed Admiral nurses delivering an amazing service for vulnerable carers. I think it's always nice to reinforce some of the really positive work that's happening. It's a great national hotline number, but we've even got workers delivering it as well. I think it's a really success story for Rutland.
And we were the first in LLR, which I'm really proud of. Sorry, Janet.
Yeah, can I add to that? Leicestershire, at this moment in time, has one Admiral Nurse Service in one PCN area. I think in Charnwood. Is that a PCN? And the funding runs out for that at Christmas, and that's all they've got. We've got so much more, and we've received positive feedback, so yeah, it's good.
I think it's one of our areas of excellence, and I think we need to shout that very loudly. Okay, any other comments about today's meeting? Any other observations? Well, thank you. You can come again. Right, I'd like to declare this meeting closed at, oh, look at that, 1 minute, 2 minutes past 4. I have achieved it again. You can tell I'm tired.
Just that, date of next meeting, I'm sure that should be 2025, you know.